So anyway, I feel very privileged to be moderating this highly esteemed group that I'm getting ready to introduce. Dr. Sufna Brown, on my right, is an assistant professor at the University of Arkansas for Medical Sciences, College of Medicine, Department of Psychiatry. She's a nationally certified clinician in several evidence-based treatments for children who have been exposed to trauma, including trauma-focused cognitive behavior therapy, parent-child interaction therapy, and child-parent psychotherapy. Additionally, she's a co-developer of Managing Youth with Traumatic Experiences program, a group curriculum designed for parents of young children who have been exposed to trauma. She's also a co-investigator on Arkansas Building Effective Services for Trauma, also known as Our Best. Next, Dr. Teresa Kramer is a professor and the chief psychologist in the UAMS Psychiatric Research Institute. She provides trauma services to children and adults and has conducted research in mental health assessment, outcomes, and quality of care with a specialty in trauma. She's the director of Arkansas Building Effective Services for Trauma, Our Best, a statewide program to provide evidence-based care for children who have experienced trauma. She's published more than 70 peer-reviewed articles. Next, we have Dr. Nikki Edge. She's an associate professor in the University of Arkansas for Medical Sciences in the Department of Family and Preventive Medicine. She conducts research on factors that place children at risk for poor social and emotional outcomes and designs and evaluates intervention for these high-risk children and families. Her specific areas of focus include children and families impacted by maternal substance use, depression, and traumatic events such as abuse or neglect, and she has published widely in these areas. She also focuses on interventions in early care and education settings designed to build social and emotional skills in young children. She directs an early childhood mental health consultation program in Arkansas called Project Play, as well as a teacher training and coaching program called REACH. And she's also an evaluator for Our Best. And then on the end there, we have Dr. Karen Farst. She's a child abuse pediatrician at the Arkansas Children's Hospital. She's an associate professor in the College of Medicine, Department of Pediatrics at the University of Arkansas for Medical Sciences, and the director of the university's Center for Children at Risk. She's a past president of the National Children's Alliance Board of Directors. She earned her BA and MD from Texas Tech University and then completed a residency in internal medicine and pediatrics at UAMS. Following a child abuse fellowship at Cincinnati Children's Hospital, she completed a Master's of Public Health from Faye Bozeman College of Public Health at UAMS. So please welcome all of these doctors for me. So I'm going to start with a question for Dr. Farst. And my first question, and maybe question that some of you might have, is what is a child abuse pediatrician? I mean, can you talk a little bit about what your job is?
Sure, thank you. And it's been interesting and encouraging to be here this morning. I think we all have such a different role and insight, but we're all kind of obviously looking at the same issue and the same problem. A child abuse pediatrician, I was kind of raised and trained as a pediatrician just to do primary care, and I was in private practice for several years before I became involved with the Children's Advocacy Center in the community where I was practicing, and started to realize that really to be able to do justice to kids that were entering the system with abuse or neglect, there really needed to be a team approach. And so that's kind of what drew me in, was to bring kind of the knowledge from the medical side of not only just injuries that happen to kids and trying to figure out what's accident or abuse, but also what's going on in those families and how to try to advocate to plug kids into the needed care that they need afterwards. So it's an interesting job. I actually don't spend a ton of time kind of walking the floors of the hospital per se. I'm out in the courts a lot, do a lot of teaching, that type of thing. And and I also get to interact with a lot of great colleagues as we try to work on services. I think we all might have our own kind of definition of what trauma-informed care is. For me, it's a trauma-sensitive approach to kids that are recognized as being abused or neglected. And that, I think, just a shout out before the First Lady leaves, as far as just I think the emphasis that there's been on building the network of children's advocacy centers in the state, because that does give kids a place to go where people come to them to meet them for the services they need, instead of making the child try to figure out how to navigate that system. And so I think being trauma sensitive about how we start to deal with kids, but then on the other end of it, I've written thousands of reports after we've recognized that a child was abused and said, this child needs assessed for trauma-focused cognitive behavioral therapy, which you'll hear, I think, more about our best. And so the kind of the trauma-informed concept, I think no matter where you are, even if you're not a mental health professional, I think we all have a role to play in being trauma sensitive, and then making sure that we are advocating for the type of services to get kids into in order to kind of deal with the trauma. I think, we've talked about in that last session that we have sometimes a very reactionary system. One of the also privileges of my job is I get to work very closely with DCFS and the Arkansas State Police. And I see us really kind of in that reactionary of we wait for something bad to happen to a child and then we call DCFS. And that's really not a way that we're ever kind of make a difference in this. And again, I appreciate the First Lady's support and the leadership of DCFS and DHS, that I think we've heard more about how do we strengthen families, how do we kind of keep from getting to have to recognize kids that have had really bad things happen to them. And that's probably what we try to see with healthcare now too, is we need to switch from where we try to intervene before the disease happens. So let's try to change our paradox to how we try to strengthen families before we have to try to pass bad things down to DCFS. I see them that all they get to do sometimes is just to react to crisis. And so how can we ever expect that our communities get stronger if we're really just kind of waiting on bad things to happen? And it usually is my role to bring bad news to people. And so I'm the one that kind of says, here's some of the stuff that we see that we need to do better. But I'm also really encouraged this morning because I know so many of you out there basically dedicate your lives to trying to improve services for all the kids and families that we're talking about. So thank you for being here. And thank you all for, I think, all the work that you've done to really improve access to trauma-focused therapy in the state, too.
Thank you. Dr. Kramer, do you want to talk a little bit about what services are available when we learn that families have trauma?
Okay, you turn it on. Okay. Yes, thank you. Thank you. I want to reiterate what you said. The First Lady, Mrs. Susan Hutchinson, has been one of the strongest advocates that these children have had in the state for many years. And I just really want to thank you. You never fail to get up and advocate for these children. And one of the things that you always say is you talk about trauma-focused cognitive behavioral therapy, and you're actually able to say it. So, yeah. So we really want to thank you. I want to talk a little bit about the good news. Since 2009, we've actually been working on a systemic approach to deal with children who have experienced abuse through our state legislature. And at that time, they appropriated funding from a beer tax at the kind of the advocacy of Senator Malone to have funding set aside so that we could improve care for these children across the state. And the very first thing that we became aware of when we began working in this area is that we needed to build capacity. Many of the therapists who are out there in Arkansas didn't have the skill set to be able to deal well with these children and to provide them with the kinds of treatment that we know are effective. And again, it kind of goes back to that theme, 50% of what you learn is wrong. But there's this huge gap that they just didn't learn it. And I can't tell you how many therapists came up to us while we were doing these trainings. We brought in a national trainer across the state, and they would say, oh my gosh, I can't tell you how helpful this is because we just really didn't know what we needed to be doing with these children. So the first training that we rolled out was the trauma-focused cognitive behavioral therapy, which is actually a very brief intervention, 10 to 12 sessions, to give kids the skill set that they need to begin their recovery, and then also learn that you are not your trauma. You are so much more than that trauma. So then they began to develop more of that resiliency and to be able to understand this is not their fault. This is something that happened to them, that some adult perpetrated on them, and that they can begin to then recover and develop into those skills that we want to see them as adolescents and or adults. So that was the first place that we started, and since then we've trained 1,500 or more mental health therapists across the state in the TFCBT. So I'm really proud of the whole team that's worked on this, and there are actually several of us, and raise your hand in the audience if you're a member of the Our Best team. Later on, if you want to talk to them, please, you know who they are. So we've done that. I think we were pretty successful with that. So we've actually started training for 2 other evidence-based treatments. And Mrs. Hutchinson, now you're going to have to learn some new ones. The child-parent psychotherapy, which is for children who have experienced trauma and their caregiver, and those children are anywhere from 0 to 4 to 5 years of age. And then parent-child interaction therapy, which is usually about between 3 to 7 years of age, and those involve the caregiver as well. So we've started rolling those out. We've got several training cohorts that are going on right now. We also provide consultation calls so that they can get technical assistance while they're trying to learn this. We have also made a commitment that we are going to do training for adult trauma. This goes a little bit beyond the child realm, but as everyone has talked about, there is so much intergenerational trauma that occurs, and there is an evidence-based treatment that is a brief treatment that I actually use in my clinic to really help women and men who have experienced trauma as either children or adolescents so that they can begin their recovery. It's a very strong treatment, and I'm really a full-fledged advocate of this. So we're actually going to start rolling that out hopefully in the spring. The other 2 areas that we are very committed to communicating and teaching and training others about trauma-informed care systems. So we've developed curricula to address the courts, child welfare, mental health professional settings, so that they can begin to really understand trauma and to ask that question, not what's wrong with you, but what's happened to you. And to create kind of that safe atmosphere for a child when they're coming in to get treatment or to get assistance, to get support. To give workers the knowledge of how to assess, how to identify children who have been exposed to trauma, to connect them with referral sources. And one of the things that we've done is on our website, our best, arbest.uams.edu, you can actually go online, you can look up, if you're in Faulkner County, who are the therapists who have been trained in that county in the TFCBT. So basically what we're trying to do is really create that network so that people can actually know what's happening, who's been trained, who are the skilled professionals in your area that you can refer children to if you're a teacher, or if you are a primary care physician, or you're a child welfare worker. The third area that we really are working on is to provide direct services. We do that through our child advocacy centers here in Arkansas. They are our frontline providers. They see these children when there is that first outcry of abuse. They conduct the forensic investigation. They work very closely with law enforcement personnel and other individuals who are involved in that case and provide mental health services on site for those children. So we work work with them. We fund a lot of the services that they actually provide to those children. And then we also work in a kind of a network capacity with other mental health professionals who are affiliated with those child advocacy centers. So all this we've been kind of working on since 2009. We still have a long way to go. We have a lot more training to do. We need to get more providers out there in the rural areas. I really think we need to work on televideo, psychotherapy, so that we can reach those who are hard to reach, the underserved populations. But I think we've made a really good start, so that's the good news.
It is some good news. Thank you. Just to think that we've gone from 0 to 1,500 people who can provide that. So Dr. John, can you talk a little bit more about that and about the MITE program as well?
Okay, perfect. So yeah, I am also really heartened to see so many people in the room that are committed to a similar cause that is really important in protecting our children and helping them heal after difficult things have happened to families. And so I am a member of the Our Best team, happily, and there has been a lot of great work that has been done in our state thus far to really help address the difficulties that we know exist out there that are not often talked about in the way that they should be. And so, you know, before we get into maybe the MITE program, which is exceptionally important, I think one of the things that might be helpful is to zoom in a little bit into actually what this looks like for children and adolescents. I think a lot of times we talk about how difficult trauma is to endure for a family without knowing, like, what would that look like? Like, would I be able to recognize that if I saw these symptoms in a child? Would I be able to recognize it if I saw them in an infant? And so really what one of our goals is to help understand how trauma can impact children across development as well as across domains, okay? So maybe what we can do is get started with infants and toddlers, because I think that's the area in which most people tend to have the least training and maybe the least comfort with identifying what would a traumatized infant look like? How would I even know how to address that? And so one of the keys to know about trauma is it impacts development. It gets in the way of people being able to develop in the capacities we need them to. We know this is true from the lifelong course of difficulties we have in things like speech and language development, sensory processing. So we know that these children are actually interfacing with multiple service providers. So it may be that an OT is the first person, an occupational therapist is the first person that may lay eyes on a child who needs our help across systems. Okay, so we're looking for developmental gaps, things that are not occurring in the way that they should be. Similarly, I think what stands out to a lot of us is the overreactive kids, the kids who have temper tantrums and we have no idea why, the kids who are really, really fussy and we have difficulties in soothing them. And sometimes we forget about those kids who are really under-responsive, the little infants who don't cry ever, which is not normal. The little toddlers who, when their parents leave the room, just keep playing. That's also not typical of development. And so I think what we need to do is take a really educated and balanced stance at navigating these things and recognizing what trauma symptoms can look like early on. Then when we proceed, we might see trauma look more like what we would expect from an adult. As kids get into the school age and adolescent range, they might be able to better verbalize to us having things like flashbacks, being hypervigilant and really kind of on alert of things around them. But we have to be paying attention, we have to be listening to the things that they tell us are happening to them. Okay? I don't know how many kids have been in my office as a provider and told me, oh, this is what's going on, but don't tell my mom. And my first response is, why, right? I mean, your mom is probably the person who can help you so much more than I can as a person who sees you once a week. Why wouldn't I tell your mom? And they said, she couldn't handle it. And I think a lot of kids get the idea from adults that we cannot tolerate or handle the bad things that have happened to them. Because when we don't talk about trauma openly, we force young children to deal with it alone. We force them to make sense of experiences that as adults we have panels to make sense of, right? And that's what we're asking our children to do without the help of adults who are willing to speak the unspeakable. Then as we get into adolescence, we may see things that get kids into the juvenile justice system. I think we just had a fantastic panel talking a lot about the intersection between criminal justice and trauma. We see kids engaging in high-risk behaviors, teenage pregnancy, as well as a lot of those emotional difficulties that lead to things like suicidality and self-harm. And so to balance all of this, this is what the difficult things that we're looking at, I want to assure you we know what works. We have treatments that work and that we're training people on across the state that we know disrupt this trajectory. We know that we can help you not only with the behavioral and emotional symptoms that you have, but down to your biology. We know we can rewire the way your stress systems work on a biological level through therapy. And so I am very encouraged to see, again, so many people who are excited and really passionate about this area because I think as adults, we're the ones who are responsible for helping children heal from the difficult things that they've experienced.
Thank you. That was that's a lot of wonderful, wonderful information. So as you're talking, I'm thinking about an incident that I just heard just recently doing a training. Teacher and director were asking me how to deal with the behavior that a particular child was having, and he was just having meltdowns and crying for an hour when he was brought in and being defiant during the day. And so I said, well, has there been any changes in his family lately? And they said, well, Dad's been incarcerated, Mom's working 2 jobs, and so in a typical week, he sleeps in 5 different homes during the week, grandma, auntie, whatever. So I guess my question, and I think, Dr. Edge, you know a little bit about what's out there in the field. How does a teacher know when that child has experienced trauma? Because it's not always like, how much behavior comes out before we call it trauma. And so just kind of go ahead.
So one thing that we tell teachers oftentimes is that you might not know what's gone on with the children in your class, but we can almost guarantee that there is at least one child and probably many more in your class that have experienced significant traumatic events. And one thing that we try to help teachers understand is that sometimes behavior is the sign or the signal that something's off track, that perhaps something's gone wrong. And what we find is that's not part of the training. Again, we're back to the theme of what we didn't learn in school. Teachers weren't trained about trauma. Teachers don't know that there's a connection between behavior and trauma. So they don't know that the child that they're seeing in their class that's tantruming, that's hitting, kicking, biting, spitting, cursing, running away from them, that has something to do with this bomb that they'll drop on us. They'll tell us all about this behavior, and they'll say, I don't know if this could be related, but this is what we heard happened to him. We know he's in foster care because of this. Or he saw Dad do this to Mom, and now Dad's in jail. He saw this terrible thing happen to his 4-year-old sister. Do you think that has something to do with this? And we say, yeah, I think it has something to do with it. But then they aren't trained to know what to do with that. And so what we really try to do with teachers is empower them that it doesn't take a mental health professional to support a child. Kids need that. Kids need high quality treatment. But all of us can do things to support kids. We can have trauma-informed classrooms that are good for every child in the class and are essential for the children in that class who've had experiences we may not know anything about. We know that kids who've experienced abuse or neglect are at incredible risk of suspension and expulsion, even from their childcare and early learning settings. In our state, it's very exciting. We're one of the first states to have a centralized place for teachers to get help when behavior is out of control and they can't manage it. It's called Behavior Help. It's operated out of our Division of Childcare. And about 40% of the cases that are called in where teachers say, this 3-year-old is out of control. I can't teach this class because of this child and their behavior. About 40% of the time, there's a known trauma right at the outset. There's something terrible that has happened to this child and to this family. And I'm going to tell y'all, I've been hanging around child welfare for a long time. I've been a CASA volunteer for 10 years, and I've never heard stories like these. I've never heard young children who've experienced more terrible things than we hear from their teacher who says, you know, this is what foster mom said happened, or this is what mom told us went on in the home. And so we have to arm them with tools. And so we have incredible helpers in this state. That's part of the good news. So we have staff at DHS. We have technical assistance providers at A-State. One of them is here. Wave your hand. Yeah. We have mental health consultants with programs like Project Play who go in and support teachers, who will go in every week and dialogue with the teacher, put their brain together and say, what do we do to make this classroom feel safer for this child? What do we do to teach this child how to cope with their big feelings? We forget that kids who've experienced trauma are not walking in the classroom ready to learn. The part of their brain that's in charge of paying attention and focus and memory and planning and following directions and learning is offline because they're in survival mode. So how do we teach a teacher to have a safe classroom, a classroom where that child knows every day when they walk in, they know what's going to happen? They know they have a nurturing person who's going to be with them for the next 8 hours. They can count on predictability and routine, and they're in a nurturing and enriched environment where they can relax and learn. And so that's the experience we want for every child that has experienced trauma. And it's a challenge. You know, our child welfare system is pretty taxed, pretty maxed out just thinking about how to get a safe home environment. You know, but we have to think beyond the home. We have to think about all the places that children go, whether that is the mental health clinic, whether that's their classroom, you know, whether that's the juvenile justice system, wherever they are, we want it to be trauma informed.
Thank you. Did anybody else have something to add, or does anybody have a question that comes to mind? Yes.
Back here?
Okay. Two things. One, I hope everyone is aware of the program run through UAMS Pediatrics, the PACE program, where anyone in the room not heard of that? PACE, Project for Adolescent and Child Evaluation. Everybody's heard of it? Oh, no, if you haven't heard of it, raise your hand. Okay, it's a multidisciplinary evaluation done on every kid within 60 days of going into foster care. It's things that caregivers need, that schools need, that speech therapists need, that pediatricians need, that school nurses need. And initially, it was to be available through a portal that individual practitioners and schools could access on individual kids. And that part of the program was not funded. And that leaves vital information on a computer disk and in file drawers that's not there to help the kids. So that's the sermon point. The other thing is, I get outside of Central Arkansas on a regular basis, and once you get past being able to see the tall buildings, that's where the paddling at school starts. And the majority of kids in Arkansas who get paddled are African American males with a special education designation. So what can we do as a state to educate the public, parents, and school administrators that taking a child who's been to Afghanistan every night when they go home and spends every weekend or every other weekend in Afghanistan, that they then come to school for help and get physically assaulted with a board? Thank you.
I'll address a little bit of how we talk to teachers and principals and others about this idea. Again, it's this idea of punishment, and we punish because we don't know what else to do. I mean, they think that they're helping. They want to help shape this child's behavior, and what we miss sometimes is that, you know, kids are showing us with their behavior that they have a skill gap. And so they have delays that, as you said, so many of these kids have delays in their development. Well, they have delays in their social and emotional development too. And so we really have to be reminding our teachers and teaching our teachers what they may not have learned in school, which is that we can teach social skills and emotional skills and, behavior, positive behavior guidance, just like we can teach kids any other skills. So we can teach kids how to calm down when they're angry. We know how to do that. We can teach kids how to problem solve instead of fight. We have ways that we teach teachers to do this when kids are 3 years old. We can certainly do it all the way up the line. But we have to practice these kids who are behind, just like, if a kid doesn't know how to tie their shoe, they're not going to learn the first time you show them. Well, the first time they fight with their peer and you want to teach them steps to problem solving, they're not going to get it the first time. It requires kind of patient teaching over and over. And so I think we have to have that mind shift of that we're going to teach to the skill gap. We're going to teach them the skill that they're missing. We're going to identify what it is that's getting them in trouble, and we're going to teach the skill that they're missing, because punishing without giving them a skill replacement is really going to do us no good, and it's re-traumatizing. And I think that's not the intent of the folks that are out there that are re-traumatizing the kids.
And from the parent standpoint, we obviously see folks that something that started with paddling becomes totally lost my temper through the child. There's a broken bone, or somebody that whips somebody with a cord and leaves scars. And when we talk to those parents, they don't see that as physical abuse, even though it meets our Arkansas definition of physical abuse. And so many of them, say, well, they are modeling how they were raised, obviously, so it's a norm. And so really, I think to answer your question, Dr. Field, what we've talked about as far as kind of changing the fact that we have to get into people's homes and kind of into their lives as far as teaching positive parenting. From a pediatrician standpoint, we get 10 minutes to do kind of their well-child visits, and we're supposed to cover everything about parenting and prevention, and don't let your kids stick their fingers in the electric socket, and you got to do a car seat. And we don't really promote that visit to the pediatrician's office is a time where they have time to sit down and talk about why positive parenting is so much better than negative parenting. And so it's really, again, to me, kind of this shift of working to kind of strengthen families and have our system focus on that instead of waiting kind of from a reactionary standpoint till there's been a problem.
Yeah, I think to echo what everyone is saying, one of my favorite quotes as a therapist is, parenting comes naturally, but it comes the way you were parented. And I think that is very profound when we think about how adults treat children and what messages we send to children. We often expect adults to have capacities and skills that they themselves never experienced. And I think we sometimes have a lot more grace for children who are lacking in a skill than we do for adults in their life who are lacking in a skill. If anybody is a parent around here, you know what it does to your blood pressure when you have a child who is screaming relentlessly for minutes and minutes and minutes on end, that is exhausting, and it actually puts your body into a state of stress reactivity. And what we do when we're stressed, we go back to what we know. That's what everybody does when they're stressed. And so I think when we have a conversation about how we can help children, it automatically has to include a conversation about how we can help adults.
Yeah, I think a reoccurring theme that has, for the last couple of sessions, is that there's a lot of parents who are under stress, who need help, and we've talked about two kind of obvious entry places: the criminal justice system, which is not too late, but certainly down the road. But one of the early places that I think was kind of a reoccurring theme here is in prevention for that younger generation. And that entry place for a lot of children is early child care. But as we have, somebody mentioned in the previous session how the law enforcement are expected to be mental health providers, we expect a lot from very low paid early child care providers. We did a quick study a couple years ago, and in Arkansas, the food insecurity among early child care providers, not their families, but the folks that we're asking to be part mental health, part teacher, part parent, part adult educator, those people we estimated the food insecurity among those people, they're not getting paid enough to feed their families, was double the national average. If we're going to do something, we have to enrich the infrastructure that has the potential of saving us the money that is now going into the criminal justice system.
Thank you. And I mean, I can say I know teachers that work 2 jobs. You know, they have to hurry up and leave at 4:30 so they can get to their second job so they can pay all their bills. And these are the people who are tasked with the responsibility of brain development, that brain development in those early childhood years. And to tag on to what you said, there's a huge disparity in the teacher preparation because we can have somebody come in to be an assistant teacher who has a GED, but we may also have a master's degree teacher. But there's not the continuum is there, but there's so many of our children that are most vulnerable are not in the places that have the certified teachers, and it's something to keep in mind. And I wanted to ask you all, because sometimes a teacher will tell a story, and I'm going like, oh, this is trauma, and I might give them a flyer, our best flyer, and they'll say, oh, the grandparents, they won't do that. They're too embarrassed. They don't want anybody to know. So how do teachers face that the families they don't even want to talk about it, much less reach out for their therapeutic services?
Well, I guess I do think that, especially in the rural areas, that getting mental health treatment is very stigmatizing. I think one of the things that we need to do is to have more availability within primary care so that people can go to their primary care physician and they can get treatment services right there on site, or through telepsychology or telepsychotherapy, which is one of the projects that we're currently doing through UAMS. I think it really reduces the stigma to be able to have that availability. But I also think just as a culture, we really need to work on this aspect that, yes, trauma happens, it's not your fault, but it does have some very negative consequences for you and possibly for your family. And being able to really do that outreach and that education more to parents and to family members and to teachers so that they can kind of destigmatize this whole issue of trauma and the effects that it has on an individual really is important. And I think that's everybody's job that's in this room, is to be able to start being the ambassadors and those champions who can really say, this stuff bad things do happen to kids, and it's not their fault and it's not your fault necessarily as a parent if you're not the perpetrator, but getting help is the best thing that you can do for your child.
Something that I've found also that can be helpful is pulling these difficulties into like a medical analogy. Like if your child had cancer, you would go and get them chemotherapy and radiation. If your child had diabetes, you would get them the insulin they need. Please help me to provide your child with the medicine they need after something has happened to them. I think mental health gets stigmatized and polarized as something entirely different than physical medicine when we know that's simply not the case. And so I think sometimes it's really helpful for parents to feel empowered that they are taking care of their child's health needs by taking care of their child's mental health needs.
Hi, thanks. I think you touched on this a little bit, but you mentioned the toolkit that you can give teachers or early child care providers. And I'm kind of wondering, what are the top couple of tools that you offer? I know you mentioned, you kind of touched on conflict resolution examples and stuff. What are the best tools in the toolbox that you could talk about?
Well, a few things. So we actually have a literal toolkit that's a child care, child welfare communication toolkit, because the first thing we have to do is get the teacher out of the dark. If we don't know what happened, we can't be very helpful. And so we have to help the teacher get empowered to be part of the team and ask questions about this child's experience and then be able to work from there. Some of the most common problems that we see, of course, that are going to drive a teacher crazy are problems with aggression. And so some of the first things that we work with teachers on are strategies to help teach kids to identify their feelings. A kid's never going to come up to you and say, I think this feeling in the pit of my stomach is anxiety because I'm worried if mom is going to come back at the end of the day. And so we have to be able to articulate for the child, be able to give them words. And once they kind of have words and can know what it is that they're feeling angry when their friend took their toy, that they're feeling scared about what's going to happen at home tonight, then they can have words to talk about it, and we can teach them ways to calm. And so we do deep breathing. Again, these are things we want teachers to practice day in and day out. So it's just like I think Sufna said earlier, there's only so much we can do when we see you once a week. It's these people who are in the kids' lives day in, day out. Teacher can practice breathing with them every day, and they'll carry that with them for the rest of their lives. A conflict resolution, is another one. So we have mental health consultants and technical assistance providers that work with teachers to give them these skills. We have programs like REACH that Teri directs, where they literally take them a toolkit every month and give them new tools to work with the kids. So they're pretty simple strategies. It just takes kind of patience and time because it's learning new skills.
Yeah, it's always nice to hear when people in different disciplines do such similar things, right? I think we get siloed really easily, and the fact that what's happening in early childhood education is so similar to what would be happening in a therapist's office, right, is nice to see that consistency. What I want to emphasize is that when we teach children skills, it has to be within the context of an adult relationship that they have. So children develop within the context of relationships. And so we can't expect to teach a 3-year-old something and then they learn it and use it. It has to be taught within the context of those interactions that you mentioned, Nikki, and it has to be continually reinforced by people who mean something to a child in order for those skills to develop and really take root.
Thank you for reminding me that the most important thing, the first thing we always teach teachers to do is have a moment of connection with a child every day. Warmly greet them. It can be as simple as that. If you'll take 2 minutes and play with a child that's having significant symptoms of trauma and behavior concerns, usually behavior concerns will reduce by about half from 2 minutes of one-on-one, just focused, teacher-child time. We see new studies coming out about this all the time, so it really is that relational piece. The child has to know you love and care about them before anything else can be effective.
I think one thing that always concerns me, I work in the school system, and is that teachers aren't taught this information at the collegiate level. It needs to be a part of every single teacher's curriculum, and I know very, very good veteran teachers who do still not understand, 20 and 30-year teachers, the basis for this behavior that drives them crazy every day. And then another thing, Dr. John, about mental health, I'm sure you'll agree, if it were more readily affordable and more equally covered under health insurance, it would remove some of the way that people think, as far as that we get treatment for people who are physically ill because they're throwing up or they have a sore throat or whatever, but for the things that we can't see, we disregard them financially.
And thanks for that comment. And Dr. Meese's statement this morning keeps coming up that it's not only that half of what you were taught was wrong, you weren't taught at least half of what you need to know as well. And I would tell you from medical school, we do a terrible job teaching about abuse. Nursing school, I think it goes across. And I think from a state standpoint, that's one thing I think we can do is advocate for just kind of basic adverse childhood experience, toxic stress stuff to be a core curriculum. There are some folks doing that around the country that are really kind of picking on specific colleges within, like for social work, that if you're going to get a social work degree, there has to be a core class in child abuse or toxic stress or that type of thing. So, I mean, I think those things are possible. It obviously takes kind of a galvanized effort to change educational curriculum, but it is a core part of what we deal with as a country and from a public health standpoint. So I think it's a great thing to move forward on, because nobody is taught what they need to know about child abuse and toxic stress in their kind of collegiate level.
Hi, I work with the health department and I work with our school nurses. And I just want to put a plug for how important that role is when we talk about the teachers and how they identify, because they may be the first child, the first one that sees the child. So I hope that we can put some efforts into our school nurses as we're educating our teachers. But I just want to put that plug in.
I hate to be so blatantly plugging my own work, but I can't stand it. A lot of you, but maybe there's somebody in the room who doesn't know that one of the tools that we have developed with funding from Division and other funding from the feds is a tool that's used to help teachers engage with parents so they can have these serious conversations, and it's not just conversations about how's your day and what the weather's like. It's a tool called the Family Map, but as part of that implementation of that tool, we train educators in a 6-hour training how to use the tool, but also how it can be used to really up that conversation with parents so that they can be preempted. They don't have to wait until the car crash. They can anticipate what the family is going to need. And further, one of my colleagues has taken the data from those projects, and we've realized that it is an early ACEs screener. So we have documented and peer-reviewed articles that show that within the context of this very friendly parent-teacher conversation, you can get a good handle on what this child's early as 2 and 3 year old ACEs are without having to have a conversation with the parent that is intrusive or asks about more sensitive things. The goal is to increase the partnership rather than to put anybody in a defensive mode. So if you don't know about it and want information, my colleagues are spread out around the room, but I'll be glad to help.
Let's see. My question is, first a statement. I've been impressed that you've talked about a number of programs, many, or should I say some of which are offered around the state. You've trained a number of people. That's kind of new to me. So is the funding adequate in the state of Arkansas for?
Teri. I can talk about that all day long. I mean, I think we've done a really great job on the amount of funding that we have available, and I'm very appreciative that that has occurred. I think if we're going to continue to do this work, we are always going to need more funding. The child advocacy centers, they do have mental health professionals on site, but the funding that's available really doesn't cover the number of children. Surprisingly, last year, I think we had between 5,500 and 6,000 children who were presenting at children's advocacy centers across our state, and we're not able to get all those children into treatment. So I think that there are a number of different issues that need to be addressed, and we have to have the funding to be able to do it. I mean, you've heard a lot of different recommendations today, and of course, with every recommendation, it's how do you get that funded? But thank you for bringing that up. I appreciate it.
Yeah, that's a really, really great question. And it's also in the early childhood field as well. I mean, we're really fortunate to have state-funded ABC slots. I'm sure everybody's familiar with those, and Head Start slots. But those don't cover all the children who would be eligible for them due to their family's income, nor do they cover a full working day for parents. In other words, they've got to figure out, okay, like school ends at 2:45, but my job doesn't end until 5, or the holidays or the summers, and so children end up instead of staying with that relationship that Nikki talked about, like, whoop, now we're going to be with great grandma for the next 3 months because there's, the school's closing so for little kids, it's not like, now I'm going to the 5th grade. The little ones don't get that continuity of care because the funding's not there.
Yeah, and I will say the more that we have open discussions, the less it feels like a them issue, like it happens to certain people, and it's those people that frankly don't have an equal voice at the table systemically, as well as they're too busy working 3 jobs to be on a task force to do this kind of work. And so I think we have to really think about how do we make this a we problem, and how do we make sure that we get input from people who are living these struggles in these communities that we're trying to go in and help. Is I think we need to figure out a way to have more of those voices represented in the work that we do.
Testing, okay. We need to go upstream as far as we can go, and this is where we are weakest. And anybody of you know me will say, well, what about the 1-month-old baby? And recognizing early signs of issues with a 1-month-old baby. And we're beginning to get some tools there now, which are important. We can do with the ASQ SE2, pick up early signs of social emotional delay, which is a sign of attachment issues which need intervention. The pediatricians, well, I'm a pediatrician and I know how difficult it is to do what we're supposed to do anyway, much less add something else onto the plate. But I'm glad to see where we're making progress in therapies that will be able to treat the mother-baby dyad starting at 1 month, because that's where we need to go as the next step. And so I was interested in, you know, I know you have a program, what is it called again? Parent-child psychotherapy goes down to 1 month.
Child-parent psychotherapy, yes.
Right.
Yes, goes down to 0. I mean, as soon as they're born, you can start establishing that dyadic relationship and help that mother really do the appropriate caregiving that's necessary. The other program that we're starting, which we come back to, the Managing Youth with Traumatic Experience, actually does start very early in trying to just teach parents about the effects of trauma on their children, and then what they can actually do to kind of form that relationship. And that can be either an intervention or more on the preventive side. So it's a very brief treatment that we are actually starting to implement. But I think there, like I said, there are many things, and I think Nikki wanted to say something about that as well.
Yeah. Just one quick comment, and it goes back to something Dr. Zoller said earlier. We can't be, when we're talking about a 1-month-old that is at risk for concern, we need to be looking at what's going on with the parents that we might be feeling a little mad at. So we might be wanting to punish the parents instead of treating mom's depression or treating mom's substance use or dad's substance use. And so services for very little kids are often about services for parents that we don't have a way to pay for.
Well, I know you said you can treat the child-mother dynamic at 1 month and that it's kind of hard to gauge before then, but I think if we move it even more upstream, if we look at how much maternity leave did a mother have, was she able to breastfeed? Yeah, I mean, if those are ACEs questions for later on. I think that's an early indicator too. I mean, true enough, if FMLA guarantees them a certain amount of time, but realistically, how many mothers can take that time? True enough, it's best if you can breastfeed till 6 months. And I know we have certain state and federal laws in place, but realistically, Arkansas is not, workplaces are not breastfeeding friendly. And so we need to look at those things as well.